among men having sex with men, highlighting the disproportionate burden carried by this key population. In contrast, other males and other females referring to individuals outside of key populations account for a much smaller share of new cases. While age groups, nearly half of new infections are among young key populations, age 15 to 24 years old, underscoring the vulnerability of adolescents and young adults within high-risk groups. Focusing our efforts where transmission is most concentrated is essential to bending the curve of the epidemic. Next, please. Moving from estimates to actual next, please. Moving to estimates to actual diagnosis, as of October of this year, the Department of Health has recorded a total of 160,000 cumulative diagnosed HIV cases. This marks a significant rise from 21 new cases per day in 2015 to 56 cases per day in 2025. Increase in confirmed cases may be a cause of both increasing infections and improving case finding through expanded testing access and surveillance efforts. A major turning point came in 2019 with implementation of Republic Act number 1166, the Philippine HIV/AIDS Policy Act of 2018. This landmark legislation was principally authored and co-sponsored by our esteemed Senator Risa Ontiveros. He has publicly acknowledged her role in championing the measure and lauded its passage a significant step towards strengthening the country's HIV response. Among its key provisions, the law lowered the age of consent for HIV testing to 15, enabling adolescents to access testing services without need for parental consent. Expanded testing strategies, including community-based and differentiated HIV testing services, thereby making testing more accessible and responsive to diverse needs of population. These reforms have helped uncover more cases earlier, but they also highlight the urgent to strengthen prevention, linkage, and retention efforts to curb the epidemic growth. Next, please. Looking at the age profile of diagnosis cases, half of all confirmed HIV cases were among individuals aged 25 to 34 years old, while 30% fall within 15 to 24 age group. In fact, nearly 80% of cases are among those under 35 years old, clearly indicating that HIV continues to disproportionately affect younger populations. Sexual contact remains the predominant mode of transmission, with 82% of cases reported among males having sex with males. These figures remind us that HIV continues to affect young, sexually active populations, underscoring the need for targeted, youth-centered interventions. Next, please. In 2025, 1 in 5 newly diagnosed HIV cases presented with advanced HIV disease. This marks a notable improvement compared to previous years, with a clear downward trend in the HD diagnosis observed since 2022. This positive shift reflects progress in earlier case detection and timely diagnosis. Despite these gains, TB and pneumonia remain the leading opportunistic infections among PHIV. This underscores the urgent need to strengthen integrated care pathways that address these comorbidities, ensuring prompt diagnosis, treatment, and continuity of care for affected individuals. Next, please. Advanced HIV disease remains notably prevalent among children below 10 years old, underscoring the ongoing challenge of mother-to-child transmission. That highlights the critical need to strengthen early infant diagnosis and ensure prompt initiation of treatment for children to improve health outcomes. We also observe a higher prevalence of BHD among older adults aged 50 years old and above, suggesting that late testing and delayed diagnosis continue to be issues within this age group. Proportion of BHD is shown to be higher among non-TB populations, indicating later diagnosis for this population. These findings call for more targeted efforts to promote early HIV screening, increase awareness, and improve access to care for older populations. Next, please. As HD progresses, the immune system deteriorates, leaving individuals highly vulnerable, potentially fatal infections. To date, there have been 10,014 cumulative deaths among people living with HIV, with annual deaths among HIV cases exceeding 900 since 2022. It is important to note that mortality surveillance is conducted on a best effort basis and may not fully capture the extent of HIV-related deaths nationwide. These findings emphasize the need for a comprehensive clinical management and timely interventions to address common comorbidities associated with advanced HIV disease. Next, please. In terms of behavior patterns, the integrated HIV behavior and serologic surveillance conducted by the Department of Health revealed that a significant proportion of key populations, particularly males having sex with males, reported being sexually active. Notably, 76% engaged in anal sex with another male within the past 12 months. The majority indicated between 1 to 7 sexual acts per week, reflecting relatively frequent sexual activity within this age group. Furthermore, approximately 6% reported participation in group sex during the same period. The IHBSS revealed critical gaps in protective behaviors. On average, the median age for first sexual experience was 16, while the first condom use occurred at age 17, reflecting a 1-year delay. More concerning, the median age of first HIV test was 18, indicating a 2-year gap between initial sexual activity and testing. This behavioral lags significantly heightened the risk of HIV infections and transmission within this population. These findings indicate the protective behaviors frequently begin only after initial exposure, highlighting a critical window of vulnerability. This underscores the urgent need to strengthen early education, enhance risk and awareness, expand timely access to HIV testing services, particularly among adults and other key populations. Next, please. While prevention efforts rightly prioritize key populations, we must not overlook a critical front in the fight against HIV, protecting babies born to women living with HIV. The estimated number of pregnant women living with HIV in need of prevention of mother-child transmission services continues to rise. Yet, antiretroviral therapy coverage remains insufficient, placing infants at risk of infections. The gaps in ART access, combined with increasing HIV incidence among women living with HIV, have resulted in a troubling surge of HIV diagnosis among children under 5, with cases peaking in 2023. This trend underscores the urgent need to strengthen maternal and child health interventions with a broader HIV response. Pregnant women with HIV and their children must not be left behind. Closing the gap requires decisive action, scaling up ART coverage, reinforcing PMTCT programs, and ensuring that maternal and child health remains the heart of HIV prevention strategies. As of October of this year, our progress, as mentioned by Dr. John Junio, toward the global 95-95-95 target stands at 60, 64, 59, while only 60% of people living with HIV and antiretroviral therapy receive viral load testing. It is encouraging that 97% of those tested were virally suppressed, demonstrating the effectiveness of our antiretroviral therapy program. From an estimated 252,000 PHIV nationwide, 150,000 know their HIV status. 95,000 are currently alive on an ART. 57,000 have received viral load testing, and 56,000 are virally suppressed. However, significant leakages persist along the cascade. 102,000 PHIV remain undiagnosed. 54,000 diagnosed with PHIV are not on ART, either not yet enrolled or lost to follow-up. 39,000 PHIV and ART have not undergone viral load testing or not virally suppressed. In total, this means that 156,000 PHIV are not on life-saving treatment. If these gaps remain unaddressed, they will continue to fuel ongoing transmission, particularly among key and vulnerable populations. Closing these gaps is therefore critical to achieving epidemic control and safeguarding public health. In summary, as of October of this year, an achievement towards national HIV care cascade target stands at 60, 64, 59. Inequalities in gaps and leakages in the HIV care cascade persist, underscoring the necessity for tailored approaches implementing intervention and services. While testing has been increasing, diagnosis fails to catch up to new infections recorded annually. With new HIV infections continuing to rise, prevention efforts must be intensified. Available interventions, including pre-exposure prophylaxis and condom use, must be scaled up and effectively delivered to target populations. Without further expansion, our PrEP targets will remain out of reach. Although cases of advanced HIV disease are declining overall, children, older adults, and non-key populations, males remain disproportionately affected, pointing to persistent gaps in early detection linkage to care. At the same time, the growing number of women living with HIV highlights the urgent need to strengthen linkage to care during pregnancy and ensure adequate supplies for infant prophylaxis to prevent mother-to-child transmission. Moving forward, achieving our national HIV goals will require a multi-sectoral approach, mobilizing health facilities, local government units, community organizations, and partners to develop targeted, inclusive, and equitable interventions. The time to act is now. Every delay costs lives, but every step forward brings us closer to ending the HIV epidemic. Dahil bawat buhay ay mahalaga. Maraming salamat po for your attention.
Maraming salamat din po, Sir Noel. Could I ask one follow-up question bago ko hingin yung inputs ng ibang mga representatives ng government agencies dito? Kaugnay nung issues na ni-raise ng UNAIDS tungkol sa OHAT packages, may we get a response from PhilHealth? Paano nyo ini-intend na i-address yung issue ng reimbursement? At pwede po bang ibahagi ninyo sa komite yung initiatives nyo para i-cover yung HIV services? So who will take the question for PhilHealth? Yes, ma'am. Dr. Zala.
Yes. Good morning, Madam Senator Chair.
Morning.
Good morning, everybody. Yes, we know the concerns raised by the UNAIDS and by the BOH. PhilHealth has been working hand in hand with them to review our current OHAT package. We are aware that the current package only covers treatment. We are in the process of evaluating it, and we foresee that by next year, the first semester, we will be announcing an expanded package covering the screening, the diagnostics, and the treatment, and even the preventive care aspect. Madam Chair, if I may say, actually PhilHealth, the OHAT package has been out there since 2014, and apparently our concern is that there's really quite a low utilization for that. We don't understand. Based on our FGD, we found out actually that several treatment hubs are not actually submitting claims to PhilHealth, and among those in the data from the database of the DOH, we are only receiving 55% reimbursements for among this PLHIV. So we that aspect we cannot properly explain at this point, Madam Chair. But we will get to the bottom of that. But one thing for sure is that we're working with them to expand the package, and hopefully by next year, all cascades of care will be covered by PhilHealth. Thank you.
Salamat po. So, yung issue ng reimbursement, it's more a demand problem kung 55% lamang ng treatment hubs ang nagsasubmit ng claims? Is that the analysis of PhilHealth?
I don't have the data as to the number of facilities submitting claims, but what we have is based on the number of cases by the DOH, what we are seeing here is only 55% of these PLHIVs with claims in PhilHealth.
Can anyone speak for the treatment hubs? Kung at least anecdotally ba, unless someone has data, bakit hindi nagsasubmit ng claims sa PhilHealth? If no one has that right now, that yes, sir, Dr.
Yes, currently the DOH through our Centers for Health Development in the different regions are the ones certifying or the different treatment hubs. So we are composed of private and public treatment hubs across the country. I think the main problem, I think for private treatment hubs, there's no issues. They are able to claim their OHAT and reimburse quite efficiently, but the problem is with our public treatment hubs. As you all know, there are different mechanisms or setups at the local level. For example, at the LGU level, the reimbursements are pooled at the local level, and sometimes when we did some FGDs or interviews with their different LGUs facilities, they said that they don't know how much is being reflected on, or some of the funds are not there